Good afternoon and welcome to the first session of the American Heart Association's virtual Grand Round series on moderate aortic stenosis. We're very excited to bring you this first session, disease progression and risk in moderate aortic stenosis, the rationale for earlier therapy. A couple of quick housekeeping notes before we begin. Today's session is being recorded. All participants have been muted upon entry to reduce background noise. However, we do encourage an open and conversational discussion, so please engage and share your thoughts. Time has been dedicated at the end of today's session for a case study review and discussion, as well as Q&A. Please feel free to submit your questions via the chat at any time throughout today's session, and we will address as many questions as time allows during that dedicated portion at the end of today's call. If you prefer to ask your question verbally during the Q&A later on, please use the raise your hand feature or request to be unmuted so we can call on you directly. And to note, a recording of today's session will be available in the coming weeks as an enduring educational resource on www.heart.org/moderateAS. Welcome. My name is Devin Marie Keating. I'm a Director of Operations for Clinical Studies here at the American Heart Association, and we are very appreciative for all of your attendance today. We would like to take a second to thank Cardigan for being a supporter of the American Heart Association's Heart Valve Initiative. We are very honored to have three expert speakers with us today, leading our first session in this virtual Grand Round series. We have Dr. Srikanth Vemalapalli. Dr. Vemalapalli is an associate professor of medicine and cardiology at Duke University Health System, where he serves as medical director of the Duke Echo Lab and Cardiac Diagnostic Unit. A member of both the Duke Clinical Research Institute and the Duke Margolis Center for Health Policy, Dr. Vemalapalli is a nationally recognized expert in cardiovascular imaging, implementation science, and pragmatic trial design. His work focuses on improving care delivery and outcomes for patients with structural heart disease through data-driven innovation, health system change, and patient-centered research. Dr. Vemalapalli brings critical expertise in echocardiography and real-world evidence to the national conversation on moderate aortic stenosis. Next, we have Jeannie Hutchins, a structural heart nurse practitioner and TAVR coordinator at the University of California, Los Angeles Cardiovascular Center. In her role, Jeannie provides advanced clinical leadership across the continuum of structural heart care with a focus on patient evaluation, procedural coordination, and longitudinal management of patients undergoing transcatheter valve therapies. Jeannie brings deep expertise in multidisciplinary care coordination, patient-centered decision-making, and structural heart program operations, contributing to high-quality outcomes in complex valve disease, including aortic stenosis. And last but certainly not least, we have Misty Thoreau, the Valve Clinic Nurse Coordinator and STS-ACC TVT Registry Site Manager at Lake Charles Memorial Health System. Misty plays a central role in the development, oversight, and quality performance of the health system's structural heart and valve programs. With advanced expertise in clinical quality, registry management, and care pathway optimization, Misty is a nationally recognized leader in operational excellence and data-driven quality improvement for valve disease programs. Misty's work supports consistent, high-value care delivery for patients with aortic valve disease across the continuum. We are very appreciative of Dr. Vemalapalli, Jeannie, and Misty for their leadership and championing of target aortic stenosis registry participation at their respective sites and program-wide. Thank you to you three for being with us today. The American Heart Association and the recommendations and opinions presented by our guest speakers today may not reflect or represent the official position of the American Heart Association. These materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA or ASA. The AHA and ASA does not endorse any product or device. Disclosures for our speakers have been listed here as well. We have a wonderful and robust agenda for you all today. We'll be starting with early disease progression and rationale for earlier intervention, followed next by therapeutic context, atacicept and the Catalyst AV trial, followed by a case-based discussion identifying the at-risk moderate AS patient, and last closing with a Q&A session and discussion of the case. And with that, I will turn it over to Jeannie and Misty to kick us off with early disease progression and rationale for earlier intervention.
Thank you so much, Devin. It is an honor to partner with the American Heart Association as a speaker today. Next slide. I want to take a few minutes to set the stage for our talk and highlight the natural history and burden of moderate aortic stenosis, and to dive a little deeper into what's driving this disease progression. I'm sure many of you have been in the aortic stenosis world for some time, and I don't need to remind you of the unmet need in valvular heart disease. We know that almost 1 in 5 Americans over the age of 65 has significant valvular heart disease. And of the patients with symptomatic severe aortic stenosis, 50% remain untreated. We have all seen the patients with delayed or missed treatment opportunities and know the deadly consequences and poor quality of life that's associated. We also know that disparities still exist, especially for the elderly, women, and underrepresented populations. Next slide. The preview valve study results were released this past October at TCT. This was a study that recruited patients between 65 and 85 years of age based off of Walgreens and CVS databases. And the overall prevalence of moderate or greater valvular heart disease was 8.2%. And for aortic stenosis, 3.1%. They also saw that the prevalence of valvular heart disease progressively increased with age, so that by the time the patients were between 80 and 85 years of age, 15% of patients had moderate or greater valvular heart disease. Next. In the ARIC study, patients had echocardiograms at visit 5, and the prevalence of moderate aortic stenosis was 0.3%. So if we extrapolate that to the population of older adults living in the United States, that's approximately 180,000 older adults living with moderate or greater AS. Next slide. So as providers, we expect to hear our severe aortic stenosis patients report symptoms of dyspnea, angina, or syncope. But interestingly, in this study by Playford, we see that moderate aortic stenosis patients also have symptoms. In fact, moderate aortic stenosis patients were reporting angina and syncope at similar rates to that of our severe aortic stenosis patients. And on the B graph, you can see that women with moderate aortic stenosis are actually more likely to report dyspnea than men with moderate aortic stenosis. So bottom line here, moderate AS is associated with symptoms. Next slide. If we look at the Kaplan-Meier curve comparing survival of patients with moderate aortic stenosis to severe aortic stenosis, Strom and team found that the survival rates were nearly identical in the Australian and American populations. So the black line here represents severe aortic stenosis, and the orange line represents moderate aortic stenosis. And in graph B, you can see that these two lines are superimposed. Next. So basically, moderate AS and severe AS are associated with similar mortalities. Next slide. In the same study by Strom, looking at all-cause mortality, we see by hazard ratio that the patients with moderate aortic stenosis have potentially increased risk of death and cardiovascular mortality, regardless of their age, their sex, or the ejection fraction. Next. And when we look at the 5-year all-cause mortality and cardiovascular-related deaths, patients with moderate aortic stenosis have increased mortality at every level of ejection fraction, and to no surprise, especially when the EF is less than 40%. Next.
Great job, Jeannie. That really helps us to set the stage for why we should intervene for these patients earlier. Next slide. In this portion, I'll start with explaining the rationale behind that question and how upstream identification fits into that discussion. Next slide. Highlighting a lot of what Jeannie already mentioned, the prevalence of aortic stenosis is there, but there are still persistent challenges with how it's recognized, followed, and studied, particularly before patients reach severe disease. From a care perspective, these challenges often show up as under-recognition, inconsistent surveillance practices, and the absence of standardized systems to help ensure appropriate follow-up and referral for these patients. As we look at the figure on the right, I ask you all to consider your own system. Which of these challenges is most prevalent? Which category does it fit into? Is it primarily patient factors, physician factors, or system-related factors? Comorbid conditions and atypical presentation can obscure clinical recognition of AS. In parallel, access barriers, health disparities may limit a patient's ability to receive consistent and timely care. At the system level, care fragmentation and siloed workflows can further contribute to these delays. Finally, clinician-related factors can influence both recognition and variability in severity characterization. From a research perspective, these same challenges matter. If we cannot reliably follow patients with moderate AS, it becomes difficult to study the disease progression or evaluate emerging therapies in a meaningful way. So as we move forward, the question really becomes, how can we design a system that supports both high quality care and rigorous research earlier in the disease course? Next slide. Thank you. So this is similar to the Playford study that Jeannie just shared, also highlighting as well that symptoms are present in varying stages of aortic stenosis. This analysis by Solomon and colleagues include a large real-world cohort of over 40,000 adults with aortic stenosis, stratified by symptom status and disease severity. What stands out is the presence of potential aortic stenosis-related symptoms. It's consistently associated with a higher all-cause mortality across the spectrum of disease severity. Importantly, it's not limited just to severe AS, as Jeannie also highlighted. Whenever we look at those in the moderate range, the hazard ratios are very similar to when we look at the severe patients, especially in that asymptomatic realm. Taken together, this data suggests that symptom status provides an important risk stratification even before patients meet that traditional severity threshold, and really sets the stage for the next question. What is happening at the myocardial level during this period as this is progressing? Next slide. Thank you. Much of our understanding of cardiac damage in AS comes from the work of Dr. Philippe Généreux and colleagues, who have shown that outcomes are influenced not just by the valve obstruction, but how extensively the heart is affected. This staging framework classifies AS based on extravalvular cardiac damage using routinely available echocardiographic findings. Stage 0 reflects isolated valve disease. Stage 1 includes LV remodeling. In stage 2, which is where a vast majority of patients are when they actually undergo AVR, at that point, they're already starting to have left atrial enlargement, AFib, or secondary MR. And with those higher stages, we can see more pulmonary hypertension and RV involvement as well. It's important when you look at this as well and consider how we stage for cancer, because it is similar when you look at the way this is broken down. And just think, if we have a patient who presents who has stage 2 cancer and we tell them, okay, well, we're going to wait in 6 months to a year before seeing you again, you can see how this is really different when you look at this from a staging perspective and how we're treating AS. Now, the figure on the right, this is really the prognostic significance. That middle orange line where the star is really annotates those patients in stage 2, looking out 8 years and what their mortality outcomes were. So the green line, you can see those are patients in lower stages, and then the purple line above are those more advanced stages. Next slide. This is another really interesting study that came out not too long ago by Dayan and colleagues, really summarizing mortality patterns over time across 4 randomized trials. for patients with asymptomatic severe AS, looked at Avatar, Recovery, Early TAVR, and Evolved. Figure A shows the conservative management arm, where mortality trajectories vary substantially between trials, really highlighting the differences are closely tied to surveillance intensity and the timing of crossover to valve replacement, rather than sudden cardiac death, which was rare across these studies. However, figure B really showed the early intervention arm. And while early AVR consistently reduced those composite endpoints driven by heart failure hospitalization, individual trials did not demonstrate uniform mortality or stroke benefit. Importantly, overall mortality in the conservative arm was lowest with the trials that had more structured and frequent follow-up, which makes sense when we think about that, right? So the key message from this is not simply early intervention versus surveillance, but really that ability to identify progression and ensure that close follow-up for these patients. Next slide. Now, when looking at one of these trials and really looking at the timing of intervention, I'm going to bring forth the early TAVR trial, which randomized patients who had asymptomatic severe AS either to conservative management, basically watchful waiting, or to TAVR. Those patients randomized to TAVR, their median time to procedure was 14 days. And those patients that were randomized in the clinical surveillance arm, their median time from symptom onset to TAVR was 32 days. And that's pretty astonishing whenever we consider what the real world is really looking like as far as how quick we're treating these patients. This is largely due to the fact that these patients underwent their workup and evaluation early on, so their treatment plan was already determined, highlighting the importance of early referral to heart teams. The investigators importantly noted that this level of vigilance is really unlikely to be replicated in the real world, especially in context where AS is already undertreated. Next slide. And this is where Target AS really comes into play. I know a lot of you on this call are active participants in Target AS, and this was really launched to focus upstream in the care continuum. We know the TBT registry looks at the procedure forward, but what about what's happening prior to the patient making it to the heart team? And that is really the main benefit with this, is helping you to be able to see that upstream focus with really releasing that quality metric goal of 90 days for treatment. And when we consider the findings from phase 1 of Target AS, it was really interesting to see that 1/3 of patients who had symptomatic severe AS were not treated, and approximately half of those patients actually met that 90-day window. So when we look at the early TAVR, we saw what those timeframes were. This is another real-world example of what timing is looking at for those Target AS sites, and really helps us to be able to see where patients are earlier in their disease and how we can help to move the needle with treating these patients in a more timely manner. Next slide. When we consider the typical pathway for these patients, let's say they show up and go to their general cardiology visit, they have an echo, it shows severe AS, and they're referred to the heart team after shared decision-making, they have TAVR or SAVR. On average, that's happening 160 days. Again, real world kind of aspect what we're seeing. And if a patient is determined to not be in the severe range, maybe they have more moderate AS, then the current 2020 ACC AHA guidelines recommend a 12 to 24 month follow-up for those patients. So another important highlight from the Sethi and colleagues article was also that delaying TAVR really helps and really affects healthcare costs. So the longer patients are waiting to undergo TAVR, the more heart failure hospitalization and optimization and resources they're requiring, which again makes sense whenever we consider this disease progression. But you can see how already there are so many changes and differences from looking in clinical trial, the vigilance that's present there versus what we're seeing in actual real time. So next slide. To summarize, we really have learned 3 primary lessons from severe AS. First, delays worsen outcomes and increase cost. Second, structured surveillance improves outcomes. Third, and importantly, the trials have shown us, again, that vigilance improves outcomes, but that level does not always translate to routine care. So what can we do about this? Next slide. Dr. Chris Cook summarized current expert perspectives on treatment timing across the aortic stenosis spectrum, and this was presented at TCT last year. When looking at symptomatic severe AS, there is a broad agreement that that should occur within 1 month, prioritizing patients when needed, and then patients in that asymptomatic category with severe AS, after shared decision-making, they favor prompt AVR 3 months or less, again, in appropriate patients, and really highlighting the importance of that proactive surveillance, partnering with the heart valve team and the referrer early on, having more vigilant follow-up than what's currently recommended in the guidelines, and incorporating that digital tool to help scale and improve the follow-up processes. Now, for those patients in the moderate AS, that is where those clinical trials are actively being conducted, and we'll talk more about that as this call goes on, but really evaluating what exactly it looks like, both valve intervention and medical therapy for select patients, really underscoring the importance of identifying these patients consistently so they can be appropriately monitored and considered for emerging therapies. Next slide. This slide really highlights the central role of the Echo Lab and the heart valve team. I know we have many of you on this call that are in those categories, and you guys really are the backbone for care for these patients and for research. This goes beyond the diagnosis, but also includes that risk stratification and providing information that drives the treatment decisions, surveillance, and lifetime management conversations with these patients. Importantly, the ASE, or American Society of Echocardiography, recommends direct verbal notification to the ordering provider or covering provider when critical findings are recognized, which they consider to be severe AS now. So this can be operationalized by standardizing, embedding severity and guideline-based recommendations directly in that echo report, and treating this as a critical finding to trigger that quick and prompt communication and clinical action. Next slide. This is another kind of how-to slide, kind of taking it a step further, because those of you that are participating in Target AS, I want to ask you to pause for a moment and reflect on your current process. When a patient with moderate or severe AS is identified for sampling to be entered into Target AS, what happens next? Do you guys have a process in place? Is there a defined pathway that automatically supports surveillance and follow-up for these patients? Or does it vary based on the clinician, the setting, or the timing? Target AS really has done important work in standardizing identification and awareness, but what varies across sites is not whether the patients are identified, but how reliably the next step is occurring once that identification occurs. So these are 3 different avenues to really kind of consider as you were looking at further advancing this. Echo surveillance is really the foundation. So once moderate AS is identified, you can create or have a structured approach to help track these patients. You can incorporate the EMR, so have a way that you can pull reports automatically through your PACS or through EMR, and to be able to make sure these patients are getting the follow-up and appointments and surveillance that they need. And really a hot topic here is the technology adoption of this, using digital tools such as the echo stethoscope to help improve frontline murmur detection, or applying AI such as Ignite or natural language processing models to really help see patients with higher risk features and those that are likely to progress more rapidly. So the effectiveness of those tools really are determined as to how they're embedded into your routine clinical workflows and where they can help to prioritize patients and prompt timely follow-up. And then really the most important piece of this is how this can be integrated into your workflow. So this is what really helps to ensure that identification leads to action, whether it is having an automatic alert sent to the ordering provider when moderate or severe AS is indicated, and the ability to automatically send a referral to the heart team based on that, and being able to educate the providers on what that follow-up timing is, what the referral pathway expectations are, and I feel like most importantly, really engage the patients. Because when they understand their diagnosis, the follow-up timeline and the next step, adherence improves and the loss to follow-up is also reduced. And kind of bringing it back to the disparities that we talked about earlier in this portion, being able to identify the barriers a patient may have, such as transportation or finance, can really help if you do that on the front end to make sure these patients are able to get the timely care they need. So the goal is to help examine how identification points can be leveraged to create more reliable surveillance and escalate and engage patients over time. Next slide. So in conclusion, moderate AS is an emerging frontier with unmet clinical and research needs. Earlier identification enables structured surveillance and trial readiness. Echo labs and valve teams are uniquely positioned to lead upstream care and research in non-severe AS. And with this context in mind, the next step is understanding how emerging therapies are being evaluated within this earlier disease window, which will be covered next. Thank you so much.
Thanks, Misty. So I think we've heard from Jeannie and Misty, prevalence, epidemiology, why it's so important to be following these patients, and the fact that, frankly, moderate AS patients seem to have outcomes that are equally as bad as severe AS patients. So we're going to transition a little bit and talk about a specific factor, which is called atacicept and the Catalyst AV trial. And we're going to sort of set the stage for why earlier treatment is potentially very, very useful. Next slide. So this slide really is the key, because sometimes we think only about the valve and we forget that the valve is connected to the myocardium. And as the myocardium goes, the patient goes. So this is a slide we borrowed from Brian Lindman, and this is his figure from a paper in JAMA Cardiology. And I want you to look just in the middle. And the point being made here is that as the valve stenosis progresses, the health of the myocardium gets worse. And what you see here is that there's fibrosis that's going on, there's LVH that's going on and thickening. And really importantly, we sometimes think that when we replace the valve, we fix the problem. Well, no, we haven't. Some of this fibrosis and this LVH actually does not regress. Sometimes it does, sometimes it doesn't. And why this matters is when you think about a patient with moderate or even severe aortic stenosis, they really have what's called stage B, as in boy, heart failure. And stage B heart failure, you can see it on the bottom left there, is defined as structural heart disease, but without signs and symptoms of heart failure. And certainly as things progress, they will often either right before the time of their valve surgery or sometimes afterwards will actually develop frank heart failure symptoms and go into what we call stage C. So advance the slide, please. And that's really important because there are patients who get treated for their aortic valve stenosis and they still end up having heart failure hospitalizations and heart failure afterwards, for which we have no other potential cause other than the fact that they accumulated all this damage to their myocardium as their valve was progressing, and they're left with that now. So you can see here a potential rationale for trying to stop this process earlier. Next slide. And so here, along that spectrum of trying to go earlier, there are certainly trials of replacing or treating the valve earlier. There may even be trials in the future next where you see medical therapy that you give adjunctively to try and prevent this damage to the myocardium as the valve is getting worse. Next. So changing and moving now to the valve. Next slide. I want to give the rationale for the biochemical pathway that underlies why the valve actually becomes more calcific, and we'll then move that back to potential medical therapies. So if you look at this image figure on the left, what you can see in the top portion of the diagram is that there is inflammation, which is often being driven by inflammatory cells like monocytes, but also by lipids. That causes activation of the valve interstitial cells, and that's circled there in the dotted red lines. The activation of the valve interstitial cells, you can see that step, the cell gets activated. And then what happens is the cell can differentiate either into osteoblasts or can actually influence extracellular matrix remodeling. We'll start with that extracellular matrix remodeling. When remodeling of the extracellular matrix happens, this is where you get interstitial fibrosis. Remember what we just said on the last slide. You get fibrosis, you can get LVH. Sometimes these things are irreversible. So this is the pathway by which that happens. Now, on the other aspect, when these activated vascular interstitial cells turn into osteoblasts, so they can differentiate into osteoblasts. Osteoblasts make bone. And unfortunately, when you make bone on a valve, you get calcific aortic valve disease. And what's really unfortunate about this is a feed forward loop. So as there's bone created and deposed on the valve, that actually results in downregulation of soluble guanylate cyclase, as well as downregulation of nitric oxide, which feeds forward to more differentiation of osteoblastic cells and more calcium deposition. So this is an accelerating process. And the role of this soluble guanylate cyclase will be very important as we go forward. Next slide. So I want to show you a little bit of data about the correlation between aortic valve calcifications and cardiac function. So remember, we've been trying to draw the parallel between what's happening to the valve and what's happening to the myocardium. So in this graph on the left, what you can see here is a correlation between the amount of calcification as measured by the number of leaflets on the aortic valve that are calcified and how associated it is with subclinical LV dysfunction as measured by systolic dysfunction, which is the red, or diastolic dysfunction, which are the boxes, and they're kind of these orange boxes. And you can see, starting at the bottom, when there's just valve thickening, the amount of systolic dysfunction that you have is basically none, and you have just a little bit of diastolic dysfunction. Those error bars are just on the right side of 1. Now you go up to 1 leaflet, systolic dysfunction still none, but diastolic dysfunction again still present. Now going up to 2 leaflets at the top, you can see now we actually have a statistically significant association with systolic dysfunction, as well as an even greater association with diastolic dysfunction. So building the link between aortic valve calcification and myocardial function. And then making it more clinically relevant, you can see in the graph on the right, the likelihood of heart failure with as it relates to aortic valve calcium score. So the curve on the bottom, that's an aortic valve calcium score of 0. You can see the cumulative incidence of heart failure, whereas the curve on the top, that's an aortic valve calcium score of over 800. And so you can see this kind of stepwise progression. The more calcification you have, the more likely you are to end up with heart failure. Next slide. So another aspect of the aortic valve calcification is it's really, really predictive of what happens to the patient, even more so than Vmax, which we often use to make our diagnosis, or the aortic valve area, which we also use to make the diagnosis. And so you can see here in panel A, this is a graph of survival with non-severe versus severe aortic valve calcification. And you can see the patients who have severe aortic valve calcification have reduced survival. The forest plot just underneath that quantifies the same effect in this same study, where basically severe calcification was the only independent risk factor for mortality. So when you put it into a model with AVA and Vmax and age and male sex, this is severe calcification is the thing that falls out as being most predictive and independently predictive of survival. Next slide. So now let's come back to atacicept. Next slide. So all that stuff I told you about soluble guanylate cyclase and nitric oxide, this is where it pays dividends. So what atacicept does, you can see on the figure on the left in the red box, atacicept actually helps to reverse that reduction in nitric oxide and reduction in soluble guanylate cyclase that happens as a consequence of the inflammation on the valve and activation of the vascular interstitial cells. And so it breaks this positive feedback loop and reverses part of that biochemical mechanism of action. The graphs you see on the right are from evidence in mice, where you can actually see when they're exposed to atacicept, there's a reduction in aortic valve calcification. Next slide. Now I want to show you, we'll move from mice quickly to human beings. So this is actually phase 2 data in a small study of humans. And if you look at the graphs on the left, what they did was, for about 6 months' time, they exposed these patients to either placebo or to a dose of atacicept, and then they measured the change in the aortic valve calcium score over that time. And you can see the change or increase in calcification is less in the atacicept arm than it is in the placebo arm. Again, small study, 11 patients in placebo, 12 in atacicept. And then, as you would expect, since the calcification change was less, the reduction in aortic valve area was less in the atacicept arm as compared to the placebo arm. Next slide. So what about, measures of cardiac function? I've just spent time telling you that it's not all about the valve, and the calcification correlates with what's happening to the myocardium. Well, here's what you can see for LVEF. Remember, the placebo group had greater reduction in their AVA, had more aortic valve calcification, and as you would imagine, their LVEFs actually reduced over that period of time. Whereas in the atacicept arm, it was similar to slightly improved, actually, in terms of LVEF. Same thing with cardiac output. Reduction in cardiac output in the placebo arm, and slightly improved in the atacicept arm. Next slide. So that's kind of systolic function, if you will. What about diastolic function? So we're moving back in the chain. Typically, when the myocardium goes bad, the diastolic function is affected first, and then the systolic function. So one of the markers by echo of diastolic function is E to E prime ratio, and you can see here a higher E to E prime ratio is worse diastolic function. So you really want to have lower E to E prime ratios. Now, in the placebo arm of that study, the E to E prime ratio increased by a greater amount numerically than in the atacicept arm, although when you look at the p-value here, you can see there isn't a significant difference. And again, in terms of looking at correlation between E to E prime ratio as a measure of diastolic function and the aortic valve calcium score, look at the atacicept circles, which are the darker blue-green. They tend to be lower on the change in E to E prime, and lower on the change in aortic valve calcium score than the placebo. Next slide. So these are all what a clinician might call surrogate markers. Like, it's great that all these calcium scores are better and the EF is better, but what about the patient, right? What would they feel anything? Would they notice any difference? Well, there's a hypothesis here, which is that diastolic function is associated with or correlated with peak VO2. To take a step back, when we in cardiology are measuring someone's essentially exercise capacity, the metric that we rely on is peak VO2, right? So you've got the marathoners who can have peak VO2s of 70 or 80, and then you've got people who need heart transplants who have peak VO2s of like 10. So what you're seeing in this graph on the left is a separate study in the literature that essentially correlates diastolic function as measured by E to E prime ratio with peak VO2, such that when your E to E prime ratio is low, meaning better diastolic function, your peak VO2 is higher. So presumably you're able to exercise more. Now what you're looking at on the right, in the graph on the right, is the correlation between E to E prime ratio and aortic valve calcification. Remember, based on this and what I showed you in the last slide, we're basically saying that there's a trend towards diastolic function being better when being treated with atacicept. And so one might hypothesize that the peak VO2 or actual exercise capacity may actually be better when treated with atacicept as well, although we don't know that just yet. So what are the potential hypotheses that we might improve here? We might actually decrease the amount of LVH that happens. We may change the peak VO2 and therefore reduce symptoms. We may improve diastolic function and systolic function. And of course, we may be slowing the progression of the aortic valve calcification and loss of aortic valve area. Next slide. So here, just shown in a different way, aortic valve calcification, you can connect to all of these things. Of course, aortic valve function, but importantly, you can connect that to systolic and diastolic function. And at least in the literature, there's a connection between diastolic function and, of course, systolic function and cardiopulmonary function. So what a patient can actually do in terms of exercise capacity. Next slide. So before we kind of show you what the Catalyst AV trial is, you might be asking yourself, well, that's great. You're talking about itacigot and it does all of these things in the biochemical pathway and it's going to make the patient potentially feel better and slow aortic valve calcification. That's our hypothesis. But what is its safety? And so there's two things on the right side of the slide to pay attention to. If you look in the literature, there's about 1,000 patients across multiple different studies for multiple different potential indications of itacigot that have been exposed to itacigot. And what people really worry about with these soluble guanylate cyclase meds is that you're going to cause hypotension, basically. And what you see here in these studies in the literature, there really isn't much in the way of a safety signal. And then in the studies that I've presented in terms of the human studies, there really hasn't been any evidence of hypotension thus far. So small studies, but thus far not a concern about a safety signal. Next slide. So now moving to Catalyst AV. So what is the Catalyst AV trial and what are we trying to test? And you can see appearing here on the right, these are the important clinical questions. So what is the effect of itacigot on slowing the progression of aortic valve calcification? And then the sub-question to that we've drawn the line to here in the previous slides. So how does that change in aortic valve calcification correlate with echocardiographic measures of systolic and diastolic function? And then how do those changes correlate with cardiopulmonary function? And then what's the direct effect of itacigot on that cardiopulmonary function? Next slide. So this is a kind of trial design slide to show you what this looks like. And there are two parts to the trial, and that's because it's really a combined phase 2b, phase 3 trial. You can see the study inclusion criteria looking for patients greater than or equal to the age of 50 with moderate aortic valve calcification, an AVA of greater than or equal to 1, but less than or equal to 1.5 centimeters squared. And you can see there the Agatston units in terms of aortic valve calcification that we're looking for, 1,200 in women or 600 to 2,000 in men. LVEF greater than or equal to 45% at screening, and no contraindication to doing a CPET. And so you can see the patient will receive itacigot 200 milligrams daily or placebo because they'll be randomized. And then the primary endpoint for the part A, which is about 130 patients, is a change in aortic valve calcification at 6 months. And you can see the secondary endpoints listed there. And there's a CPET, which is the way we measure peak VO2, sub-study to understand the impact of itacigot on peak VO2. And then it moves into the larger real phase 3 trial, or part B in this trial, with about 1,150 patients planned. And again, the primary endpoint is change in aortic valve area this time at 48 weeks and change in peak VO2 at 48 weeks. You can see the secondary endpoints that are listed there. So the part A is the phase 2B trial and then moves into the larger phase 3 trial as part B. Next slide. So I want to turn it over to Jeannie and Misty to go through the case.
Great. Thanks, Dr. Vimlapalli. That was a really great review of the pathophysiology of what's happening to the heart at the molecular level with aortic stenosis, and also a review of how itacigot works and a little bit about the Catalyst trial. So, how might this patient present to us in real life? And that's what we want to talk a little bit now and do a case-based discussion of the at-risk moderate aortic stenosis patient that might be in clinic with us. Next slide. So this is an actual patient we saw at UCLA a few months ago, just prior to the holidays. He's a 76-year-old gentleman with hypertension, dyslipidemia, BPH, osteoarthritis. He had had a left total knee replacement a few years ago, and he was referred to us for the management of his aortic stenosis. Family history: father died at 80 of a heart attack, mom at 86 of pneumonia. He was a married, retired dentist, quit smoking 45 years ago. And medication-wise, he's on a statin, an ARB, multivitamin, and medication for his BPH. Next slide. In clinic, he's normotensive, heart rate is controlled. He's, slightly high BMI, not overwhelmingly, and SATs are good. On exam, it's relatively benign, except he does have a 2 out of 6 systolic murmur at the left upper sternal border. Next slide. On EKG, we can see a narrow, complex, normal sinus rhythm. Next. And here are some echo images. So if we're paying close attention to the diagram that Misty showed from Dr. Genero, showing the pathophysiology of what's happening to the left ventricle with aortic stenosis, we're paying attention to the atrium, the ventricle, and the valve. So we can see in the apical 5 chamber view with color Doppler and the parasternal long axis view, we can see there is some calcification of the valve. There is some LVH. Left atrium might be slightly dilated. The valve appears to be opening. Next. And same on the apical 3 chamber view and 3 chamber view with color Doppler. You can see some calcification, some LVH, some restriction of the leaflet motion, but valve appears to be opening. Next. So in summary, on the report, the left ventricle had normal size and function with an EF of 60–65%. Again, there was some mild LVH of the basal septum. There was grade 1 diastolic dysfunction and a mildly dilated left atrium. In terms of the numbers across the valve area calculated to 1.33 centimeters squared when the LV outflow tract diameter was 2. The Vmax was 2.6. The mean gradient was 15. And compared to his echo a year prior, the valve area had progressed from 1.7 centimeters squared the year prior. Next. So in summary, 76-year-old gentleman with hypertension, dyslipidemia, valve area 1.33, mean gradient 15, Vmax 2.6, valve area index to 0.76. This had progressed from a valve area of 1.7 the year prior. He was asymptomatic at a high functioning work level. He was normotensive and had narrow complex normal sinus rhythm on EKG. Next.
That's a great presentation, Jeannie, and we have a question for all of you. So based on what Jeannie just described and those echo findings, how would you classify this patient as having mild AS, moderate asymptomatic AS, severe asymptomatic AS, or critical AS? Again, just a reminder that EF was 60%, AVA was 1.3, Vmax was 2.6, and mean gradient was 15. So if you don't mind, answer that whole question.
We're going to give everyone kind of 10 seconds to answer and see what everyone says and have a little discussion about this, because there's some interesting aspects to those numbers and to the image.
Mm-hmm. Absolutely. Okay, so it looks like a vast majority are answering moderate asymptomatic AS as far as the answer for that patient. Any thoughts, Dr. Emily, Polly, or Jeannie, about that?
Yeah, thanks, Misty. I might say I'm pretty proud of this group. At least that's what I would have said as well. But there was some interesting things there. One is that the mean gradient was only 15. Typically, we would say for moderate AS that's between 20 and 40. Right? So we've got a little bit of discordance, which as those on the call who read echoes or see these patients know, this is pretty common to have some discordance there. The other thing that one might get thrown a little bit by is there's a little bit of LVH, but not a lot. And sometimes we are under this expectation that there's going to be a lot of LVH, and if there isn't, then we should downgrade the amount of AS that we see. And certainly, I think it's highly variable how much fibrosis and LVH people get. And then the last thing I'll point out about that echo is, Jeannie did a great job of pointing out there's left atrial dilation, there's diastolic dysfunction. Even though
Yeah.
the EF is preserved, this patient is already got structural heart damage. So this person has stage B heart failure, right? This person has heart failure, stage B heart failure. I think that's a really important concept for us. Jeannie, do you have other thoughts about it?
Yeah, I mean, I think that's a take-home message here. And as you had pointed out earlier, the difference between stage B heart failure and stage C heart failure would be, the patients that have structural disease but without symptoms, and that's him for right now. But, if we leave this alone, he will likely progress to the stage C.
Yeah, and that actually brings for me another point, which was the progression piece. So this person progressed their AVA by about 0.4 since their last echo, which if it was a year ago, their last echo, that's a little faster than what we would expect. So this is someone to be very careful of. They have stage B heart failure already. They had a fast progression. So they need to be, if you were just going to go by the 2020 guidelines, monitored pretty closely. But I think as we'll get into here, there's all kinds of options of what might happen here. Should we go to the next question?
Yes, let's go. All right, so would this patient trigger a referral to the heart team for education about AS and what to expect? Would it trigger close surveillance by the primary cardiologist with recommendation to repeat the echo in 1 year, similar to what Dr. Bimlin-Colley was mentioning? Consideration for research or clinical trial, or no need to refer this patient? He's asymptomatic from a cardiac standpoint. It's a fun question.
Yeah, so we'll give 10 seconds. I wish
Yeah,
next time we do this, we'll get the Jeopardy music going.
I know. That's what I was just thinking.
Yeah, I'm very
That sounds
interested to
long.
see the group's thoughts here.
I know, almost if we could do a select multiple, because I feel
Yeah.
okay. So 52% answered consider the patient for research or clinical trials. So Dr. Bimlin-Colley, they're listening. And then 32%, refer to the heart team for education. So that's very interesting to see a split like that.
Yeah, it's good that for the 45 minutes we've been talking, we've gotten at least some concepts across, which is great. I really want to bring this back a little bit to that consensus statement that Dr. Cook put together, and that Misty you showed. And I think that statement would suggest that potentially consideration for research as well as referral to heart team, quote unquote, would be the quote unquote right answers.
Right.
And so, I would have said either of those would be acceptable in my mind because really, I do believe that the heart team, it's not just about doing procedures. It's about being the experts and managing these patients. And that will include clinical trials. That will include, helping to get the appropriate surveillance, whether that's digital tools or other ways. So I do like those two answers. Jeannie, do you have thoughts here?
Yeah, I just think, for the past decade or more, we've all been really focused on the downstream treatment of the severe aortic stenosis patients. And as Misty pointed out in her portion, we really need to have a culture shift and start thinking about the upstream focus for these patients. We've all had the patients that are referred to us too late, right? That come in through the ER, they're in full cardiogenic shock, the EF is low, they have AKI. And then it makes it extremely tricky to start the workup for their AVR and makes either procedure, SAVR or TAVR, higher risk and includes poor outcomes. So the sooner we can change the culture and thought process to targeting the patients much earlier on in this process and educating the patients about what to expect. Misty also pointed out patients have a number of psychosocial factors and clinical factors that influence how often and how easy it is for them to follow up with us. And some patients might hear what we have to say and get it in the first take, but many patients, myself included, might need a few more conversations and our own research to come to terms with the diagnosis and what's about to happen. So the sooner we get them in to the heart team and consider them for AVR options, the better.
Yeah, I want to just invite anyone who's on, um, specifically if you have any questions at all about anything we've talked about here or not, but also if anyone who responded surveillance by the general cardiologist, wonder if I could invite any of them to kind of talk a little bit about why they chose that, whether that's what their system is or are there other considerations in thinking about that. So any questions at all, or particularly about that particular choice? While we wait to see if people have questions, I would say, it's worth talking about that choice because I think there are considerations there. I will say, for example, at Duke right now, almost certainly that patient would have gotten surveillance by their general cardiologist. And it's because I don't think we've done the work just yet to set up the system to conform to or to strive for what was in Dr. Cook's sort of expert consensus statement. So, I think we have some work to do, as I'm sure many places do. But Misty, what do you think for you all, like Charles, how would that patient have been treated?
Yeah, that you definitely read my mind on that answer because yes, I mean, ideally, referral straight to the heart team and have that evaluation or consider for clinical trial. But I mean, I think you're right. For a vast majority of places, this patient would consider to be followed by their general cardiologist, ideally at least annually. And then once they reached that severe range or had progressed symptoms, or if there were other concerns, then refer to the heart team. But I think that's definitely what this whole portion highlighted is we all have a lot of work to do as far as system changes to be able to handle this patient load, right? And to think more proactively. So yes, I mean, I do think a lot of centers would continue to have the cardiology follow up, but ideally refer to the heart team earlier, I think is, one of the main key takeaways here.
Yeah, and I would just add to that, in addition to that, creating a system to make sure that the patient doesn't fall through the cracks. We've talked about research, and actually, I'd go to next slide for a second. If it's unlikely that that patient that we just presented is going to get the opportunity to participate in research in moderate AS without being referred to the heart team. Because, for instance, you can all, everyone who's on can think to themselves right now, this slide that we're showing, which are the 3 medical/device trials on moderate AS that are in various ongoing stages at the moment. How many people outside of the heart team know about these trials or are equipped to be able to talk to the patient about the trials or enroll them in the trial? So in some respect, getting the patient to the heart team is probably not only a great thing to do from a clinical perspective to make sure they don't fall through the cracks, but it's also a great thing to do to give the patient the opportunity to benefit from research. And we know that, Misty showed the data. We know that patients who are in clinical trials who get the surveillance associated with clinical trials tend to do better overall, even if they're in the control arm. So just to show everyone here, and again, if anyone's got questions, please interrupt us or stop us. But these are the 3 ongoing trials in moderate AS. They're in various stages. Some are kind of close to enrollment, some are still enrolling. But just to point out for everyone on the call, there's going to be a lot of data about moderate AS coming in the next 12 to 24 months as these trials continue to enroll and complete. Why don't we go to the next slide then? So I do want to, in the last minute here, leave everyone with some key takeaways from this. Moderate AS is prevalent. It exists. We heard the estimate of nearly 200,000 patients in the United States just by epidemiologic estimate. And although we call moderate AS differently from severe AS, both are progressive, both are associated with poor outcomes. And you saw the curves that Jeannie presented. Moderate and severe are right on top of each other. They do badly. So earlier intervention, whether it's medical therapy or otherwise, may make a difference. And we presented to you the rationale for why that is. Next slide.
Thank you, Dr. Vemilopoli, Jeannie, and Misty. What a wonderful discussion and education. Just wanted to promote for all the folks on the call, now that we are at the top of our hour. This is the first of a 4-part series. We have sessions 2, 3, and 4 coming throughout the rest of the 2026 calendar year. So hope to see you all in April for our second session, patient identification and echo-based phenotyping. Very hot topic in this space. Thank you all for your time today. Please scan the QR code here or visit www.heart.org/moderateas for recording of today's session, additional resources, and information on future sessions. Thank you all so much.